Hey guys, today we're going to talk about diabetic crises. And when we're talking about crises, we're talking about acute ones and not ones that are cute, but the ones that are quick, fast, or dangerous. So, what are some acute crises that can happen in diabetes? So, there's hypoglycemia, which is a low blood glucose. There's hyperglycemia, which is a high blood glucose. And then we have two crises. Two like major crises aside from those. That one is these are both high blood glucose. There's what's called diabetic ketoacidosis. That's too much blood glucose. Or too high blood glucose, and there's hyperosmolar hyperglycemic syndrome, which in the name says that blood glucose is too high. So we're going to kind of break these down and look at each of these separately to better understand what they are and how we can help these patients. So let's talk about hypoglycemia. This is the only crisis where the blood sugar is low. So for this, it's usually classified as a blood glucose less than 70. And so what to keep in mind when your blood glucose is low is that your body doesn't have the energy that it needs in order to complete its task. So what do you feel like when you have no energy? So this is kind of like after a long lecture with me or something like that, how you're just kind of drowsy, you're probably irritable, a little hungry, stuff like that. And what happens is that when your body is like, man, I'm not getting what I need in order to nourish my body, I need more energy, it starts to actually jump into that fight or flight mode. It initiates that sympathetic nervous system and it stimulates for more glucose to be released. And so effectively what happens is that um, my body is trying to find some other way in order to have energy to complete the task that it's trying to get done. And one of the ways that it does it, when I'm in fight or flight mode, if a bear is chasing me and my sympathetic nervous system is activated, I'm going to get more glucose. My liver is going to release more glucose because it's like, oh, she needs a lot of glucose. A bear's chasing her. But that's effectively what hypoglycemia puts you into a mode of. So your body thinks it's starving and that you're in a crisis. And so it's like, oh my God, assimilate everything. And so maybe that helps a little bit because some glucose is released, but it also increases your heart rate and can definitely put you kind of in this panic mode. So keep in mind, if someone's having a lot of hypoglycemic episodes, it can really stress out their body and cause some cardiovascular complications. But that's a whole different other issue. Let's just focus more on a general what is hypoglycemia? So if you're looking at a patient trying to say like, okay, what are the signs and symptoms of hypoglycemia? We usually say that cold and clammy, give me candy. But you should be looking for things like their decreased level of consciousness, they're drowsy, they may be irritable, hungry, they can have an increased heart rate, heart rate, and then also can be sweaty as well. So you might notice some diaphoresis. So what's our general treatment for this? If the client is conscious, then always check their blood glucose first. So in other words, if they're conscious, that means at least that they're stable, they're awake enough. With hypoglycemia, it's super dangerous. It may seem like not a big deal, but it's super dangerous because they can go into a coma. So if they're conscious, that means that it hasn't progressed to that stage yet. So we always want to check their blood glucose first, because even though most likely hypoglycemia is what they're suffering from, we'd always like to check first if we have time to. That's only if they're conscious. And then if they are conscious and they're awake and able to eat, we use what's called the 15 rule. So we do 15 grams of carbs. We want something with fast sugar. So this is stuff like orange juice or apple juice, straight up sugar. Like, some people have like glucose tablets. They'll eat something that has a really high sugar content. So we want something that's fast, like straight sugar, to get that blood glucose up. Then it's called the 15 rule because we get 15 grams of carbs and we wait 15 minutes and we recheck that sugar. If it's still low, we're going to give another 15 grams. Once that gets to a point where it's stabilized, we want to give them, we've already given them something fast. We've given them some like pure sugar. So now we want to give them something long lasting. So after they have their fast sugar, once their blood glucose is stable, then I want to give them a protein or a fat. So this would be something like a turkey sandwich, has some protein and fat in it, or we could give them some cheese and crackers or peanut butter on some graham crackers and stuff like that. There's a lot of different options. But I want to give them something with protein and fat later. When we're emergently, my blood sugar's low, protein and fat isn't going to help me. But here's why we want to do protein and fat. I need something fast to help me when I'm acutely low. But then if I'm low, maybe there's something going on in my body that's causing me low, and I want to have that stabilized blood glucose. So protein and fat can then come to the rescue and help to stabilize over time. So that's why you want a little bit of both. So start with the 15 grams of fast acting, like the juice, the sugar, the candy, straight sugar. Then after I'm stabilized, then the protein and fat right after. If the patient is awake but not able to eat, then I can give them D50 via IV. It's an IV injection, or I can give glucagon, which can be given in the IV or in the muscle. So what about if they're not conscious? So remember I said this hypoglycemia can lead to a state of complete unconsciousness or coma. So if the patient is unconscious or unresponsive, we always want to assume hypoglycemia. Now that may seem dangerous to you, but if you know how dangerous this is, I'll tell you, I have been to many codes in the hospital where they think that the patient's heart stopped, but they were actually just hypoglycemic. So we always want to assume hypoglycemia and then treat them first. So instead of, I told you before on the last slide that if they're conscious, check a sugar first. If they're unconscious or unresponsive, unable to answer a question, I'm going to treat first. So conscious, assess first, unconscious, treat first. I'm going to assume hypoglycemia. And if they're unconscious and unresponsive, there's no way that I'm putting anything in their mouth and trying to get them to swallow anything. So I'm going to go straight to the IV or IM stuff. So I'm going to either give D50 intravenously, or I'm going to give glucagon intravenously or in their muscle. Now let's talk about hyperglycemia. Now this is talking about just a general hyperglycemia, not necessarily in a crisis yet. So a normal blood glucose is around 74 to 106, but you're very rarely going to see a patient that's actually within that range. We usually start treating blood glucose like most of the patients that are on insulin in the hospital. We're going to start giving them insulin when their blood glucose is around 150. But once we get above like the 200s, 250 to 300, we're usually starting to get into crisis. So patients can have blood glucose in the 200s, and what they have is just hyperglycemia. We want to get to it before it becomes a crisis. We definitely don't want them getting over those 300s. And so we're going to just be looking for signs and symptoms of this. So think of the three things that patients come in with when they have hyperglycemia, when they first get diagnosed with diabetes: the polyphagia, polydipsia, and polyuria. And so these are the same symptoms they're going to have when they're having just general hyperglycemia. So they'll be thirsty, hungry, and peeing a lot. Most of the time, this does not need any intravenous insulin or anything special or extra. We just need to get their enough insulin in their body to get that blood glucose down. So usually they just need to increase the dose if they already receiving insulin, or if they're not getting insulin yet, maybe they just need to get that started. But yeah, so usually just general hyperglycemia, we're just going to treat with subcutaneous insulin. So let's then go into the crisis. So when we get into crisis level, let's talk about first diabetic ketoacidosis. So diabetic ketoacidosis, what makes it different than everything we've already talked about is that it's a crisis, which means that it can have like life-threatening consequences. And it's to the point, when I say a crisis, it's to the point where the body has tried to help, and like everything the body's doing is not helping. And so, there's some intervention that needs to take place. So diabetic ketoacidosis, you're going to see that more commonly in type 1 diabetics, because type 1 diabetics more often have zero or little insulin. And because of that, pretty much what happens is that when my blood glucose, if I'm a type 1 diabetic and my blood glucose gets too high, that I do not have sugar in my cells where I need it. And so the body eventually says, I need energy, and it will start actually breaking down fat for energy in order to energize those cells. And so what happens as a byproduct of that is that it creates ketones. And these ketones actually create like a whole acid base imbalance and a lot of issues. But all of the sugar that's in my blood, not in my cells, starts to dehydrate. It literally takes all of the fluid out of my cells and dehydrates my cells and puts me into the state where I'm profoundly dehydrated. I have no energy because I don't have glucose where I need it, and I'm in the state of acidosis. So this is what really makes it different. So when you're looking at these symptoms of what makes it different, this is a crisis where I have too much sugar, I'm dehydrated, and I'm in a state of acidosis. And that's what makes diabetic ketoacidosis different different. You're going to be looking for signs of acidosis in these patients. So one thing that's big that's different is they're going to have ketones in their urine. For the other crises, they should not have ketones in their urine because ketones are a sign that I'm going into crisis, that my body's at the point that it's saying, I'm giving up on getting any glucose from you. I'm going to break down fat. They also have what's called an acetone breath. So as I'm breaking down these ketones and my body's trying to get rid of them, they're not going to just be in my urine, but you're also going to smell it on my breath because my body's trying to get rid of them because I have this excess, because I'm trying to make all this extra energy by breaking down fat. Like I mentioned, they're also going to be in a state of acidosis. So they're going to have an abnormal ABG. Their pH is going to be low. Their bicarbonate is going to be abnormal as well, because this is what we call a metabolic acidosis. Where there's an imbalance, based because because of the breakdown of all of the ketones, it puts me into the state of acidosis. And they also have what's called Kussmaul's respiration. So I'm in a metabolic acidosis. I do not have enough bicarbonate to buffer all this acid that I'm putting off. And so my lungs are going to come in and help. And if all of this sounds crazy, don't worry. We're doing acid base soon. Get excited. With Kussmaul's respirations, what happens is the lungs come in and they help to try to compensate. So with this patient, you're going to see signs of acidosis. You're going to see an abnormal ABG, and then you're going to notice this breathing they're doing. And this breathing is going to seem bad at first, but this breathing is actually how they're breathing off the acid. So remember, I told you we're peeing off the acid. We're breathing it out of my breath, like my breath stinks. And then I'm also doing these really deep, rapid breaths that are trying to breathe off more acid. So it's going to be a very deep and rapid breathing. And what that does is that helps to get off more acid. So if I have too much acid in my body is so smart. It's going to force me to breathe this deep, rapid breathing. That's Kussmaul's respirations. That's going to force some of carbon dioxide out, and carbon dioxide has acid in it. So the more I breathe off, the deeper my breaths and the faster or more breaths that I'm taking, the more acid that I'm getting out of my body. So in other words, all of these things that make the ketoacidosis different are all about the buildup of acid. So these are all the things the body's doing to get rid of acid. So that's what we're going to look for in this patient. So I told you the three problems are that we're dehydrated, our blood sugar is too high, and that we're in a state of acidosis. So what are our priorities? Well, one is going to be hydration. I need to super hydrate this patient. They're going to get a ton of IV fluid because one, their blood sugar is high. So if I give them a bunch of fluid, it's going to dilute that really high blood glucose. But remember also that when my blood glucose is high, it becomes it becomes a burglar and goes into the cell and steals all my water. So literally my cells are starving. I am so dehydrated because all the blood glucose that's really high in my blood stole all my water. So I need to replace that water. And then I need, after that, as soon as possible, I need to get that insulin drip started. The only thing that's going to fix my diabetic ketoacidosis is going to be getting that blood glucose down. First, I need to hydrate so that I stay alive long enough to reverse this, but then I need to get that insulin into my body so I can get my blood glucose down so that I can get things back to normal and stop using fat for energy. They also commonly can have electrolyte imbalances. So when someone first comes in with diabetic ketoacidosis, usually their potassium is going to be very, very high. And it's very high because usually, you know how insulin is the key to let glucose get in the cell, but insulin also works with potassium. So when insulin brings glucose into the cell, it also brings potassium into the cell. So if I don't have a lot of insulin, or if insulin's not bringing glucose into the cell, I also have a lot of potassium just hanging around. So these patients tend to have a really high potassium when they come in. But then when I give them that intravenous insulin, what happens is there's all this insulin. And remember, I said insulin is like the ride that potassium takes to get into the cell. So then I have all this insulin I'm giving this patient, then all the potassium is getting pushed into the cell. And so then I actually end up having hypoglycemia, or low potassium. So as a whole, I want to have this person attached to an EKG monitor, be monitoring that potassium closely, and really be watching for those changes, because they can have really abnormal rhythms and lethal rhythms. And then I also just want to be watching that potassium level closely, because it can definitely go up and down. And too high or too low of potassium is never good. And then if I do all of this and I still have an abnormal ABG, we may give medications like bicarbonate. Now, usually if I get my blood glucose under control, the acidosis straightens itself out. But if that doesn't work, then I can give medications like bicarbonate, or if they have a really serious problem with their acidosis. So let's look at the other type of crisis, and that's what's called HHS, or hyperosmolar hyperglycemic syndrome. Now, this is more common in type 2 diabetics, and this is just like diabetic ketoacidosis. All you have to subtract is the acidosis part. So what hyperosmolar hyperglycemic syndrome is effectively dehydration and a really high blood glucose. And so what makes it different is there's none of those signs of acidosis. There's no ketones, there's no acetone breath, there's no abnormal ABG, there's no Kussmaul's respirations. All there is a really, really high blood glucose. It's usually greater than 700. And then also the other thing that makes it different is usually that they have a marked decreased level of consciousness. Their blood glucose is so high, they have no energy, no glucose, and they're not converting to the other metabolism. But excuse me, they usually come in more decreased level of consciousness, more confused, more drowsy. So that's something you might notice. So higher blood glucose, no signs of acidosis, and a more decreased level of consciousness. So since my two big problems are hydration and then my blood glucose being too high, that's going to be my treatment. I'm going to give them tons and tons of fluid and hydrate the heck out of them. And then I'm also going to give them that insulin to get their blood glucose down so I can fix the problem. And as well, this patient, we also need to watch out for that potassium, because again, potassium works opposite with insulin. So always want to be watching it closely, have them hooked up to an EKG monitor and be looking for any changes or problems with those. I hope this was helpful to help to start to understand those acute crises of diabetes. I'll see you guys next time.